Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jennifer Blanchette. Today's episode is part of an ongoing series on addressing key challenges in the management of viral hepatitis. This series features expert discussions of developments designed to improve treatment and care for patients with hepatitis. In this episode, Professor Heiner Wedemeyer from the Hannover Medical School in Germany provides his insights on best practices for HDV diagnosis and management. For more information about our guest and for additional online education on this topic, please visit the link in the show notes. So now let's turn it over to Professor Wedemeyer.
So my name is Heiner Wedemeyer. I am the chair of the Department of Gastroenterology, Hepatology, and Endocrinology at Hannover Medical School here in Germany. Hannover Medical School is one of the leading German liver centers. We are running the largest liver transplant program in Germany, and we have a long history on treating patients with viral hepatitis and also investigating mechanisms why viruses, when they infect the liver, actually cause liver damage. Today, I want to speak about hepatitis D virus infection. In the hepatitis alphabet, D stands for devil because it definitely causes the most severe form of viral hepatitis, with many patients developing liver cirrhosis already at an early age. And it has also been shown recently that HDV infection is associated with an increased risk to develop liver cancer. So without any doubt, this is an important and severe liver disease. The points I want to discuss with you today are, if this is important, the question is, how frequent is Delta in the world and how can we actually diagnose Delta? And once we have diagnosed a severe disease, the next question then would be how to treat this severe liver disease. And we have, fortunately, new emerging treatment options. We have the first approved drug, which I could use in Germany already since 18 months now, and we have real-world experiences. And these are issues I want to discuss with you in the next minutes. So let's first start about diagnosing and screening HDV infection. We first have to understand that HDV infection is a co-infection of patients being infected with the hepatitis B virus. So we are looking for patients with hepatitis B who then in addition have antibodies against HDV. The first question is now, should I screen all hepatitis S antigen positive persons for the presence of anti-HDV? This would be one strategy that has been discussed for many decades, not to miss a single person. Here, the point is that my strategy is a clear yes. I'm applying this approach. So every hepatitis B patient should be screened for Delta. But in real world, very unfortunately, this is not the case. We have some areas in some countries who are pretty good in screening, where many Delta cases have been diagnosed. But even here in my country, in Germany, we estimate that between 5 and 10% of hepatitis B patients are anti-HDV positive, but in fact, only a minority of those patients has been diagnosed until now. And I think it's our job as experts in the field, as physicians, as patients, as advocacy groups, to really spread the knowledge about Delta, that it's really important to diagnose Delta and that we have the tools. The second point we have to keep in mind that HDV infection has a very different epidemiology worldwide. So we have some areas where the prevalence of HDV infection is very, very low. And on the other hand, there are some countries in the world where between 10, 20, even 30% of hepatitis B patients are co-infected with Delta. So, for example, Mongolia, a very high frequency of HDV infection. Pakistan, very high frequency of HDV infection. Other Central Asian republics, Turkmenistan, Uzbekistan, with high HDV prevalences, and also in some African countries, in South America, and in Europe, we have some countries with high HDV prevalences, for example, Romania, where many HBV infections infected persons have a co-infection with HDV. And what does it all mean now, for example, for me treating viral hepatitis in Germany? My patients I'm seeing with Delta, the majority of them were actually not born in Germany. So half of my patients were born in the republics from the former Soviet Union, or in patients where the families came from, for example, Eastern Turkey that moved to Germany. And then I have also some patients that were injecting drugs in the past, and they have also a higher risk for carrying HDV. When I'm describing the populations, so immigrants or persons who inject drugs or have other risk factors, you can imagine that these populations are not that easy to target. That is really a problem. So there may be language barriers. There may be cultural barriers. There may be social, economic barriers why these patients do not attend regular visits at doctors, and then also maybe why they have not been tested for hepatitis B or Delta. And that is something we are working on right now. We have to involve patient advocacy groups. We have to involve other institutions and to really highlight that Delta can be a problem in these persons. And there is not one, let's say, strategy fits all for all countries. We may need to apply different screening strategies here in Germany as compared to Romania, as compared to rural areas in Africa. And therefore, we need tools. And therefore, the question is how to diagnose an HDV infection. And I mentioned already anti-HDV. And what is the good news is that the commercial antibodies, which are available to test for antibodies against HD antigen, they are really good. So we have, they are very well standardized, and the risk to miss an infection because a screening assay is false negative, that is very low. So I think the tools are there, and we have also even now new rapid antibody screening tests. We are all learned from COVID testing that these screening assays, and they are quite easy, that and we have these rapid tests now also for Delta being developed. And now we need to make sure that they are distributed in countries with a high risk for Delta infection, and also that they are used in persons, for example, with liver cirrhosis, where the prevalence of Delta may be even higher than the numbers I mentioned earlier. So we have the tools for anti-HDV testing. But then we should not stop. If a patient is positive for anti-HDV, it's mandatory to test for HDV RNA. So because not every patient who is anti-HDV positive has actually active HDV infection. You all know this from hepatitis C. So if you have 100 persons who are anti-HCV positive, there may be only 50 or 60 who are actually viremic, who have active replicative hepatitis C virus infection. And the same holds true for Delta. So we have roughly 2/3 to 75% of anti-HDV positive patients where HDV RNA is detectable, which means on the other hand that the other quarter of patients may not require treatment. But there's a fundamental difference between hepatitis C and HDV. You all know when we treat hepatitis C, they achieve SVR, sustained virological response, and that means cure from HCV infection. The virus is gone. This is not necessarily the case in HDV infection, because there may be very low levels of virus persisting, which are maybe not under the threshold of the detection limit of your PCR assay. And then for different reasons, you may have reactivations over time. And therefore, if you have an anti-HDV positive patient who is HDV RNA negative, this patient You cannot say, okay, everything is fine, go home, you have recovered HDV. You should still follow this patient. Call this patient back every 6 to 12 months and check whether there's some reactivation of HDV RNA, which would have a meaning for the patient, because this patient then may require treatment, which I will discuss in a minute. The other point I just want to mention is that, as you know from hepatitis B, as you know from hepatitis C, that also for hepatitis D, we have different HDV genotypes. At least 8 different genotypes have been described thus far. There may be more. But the point is that in the majority of cases, for example, in Central Europe, also in North America, the far majority of patients are infected with HDV genotype 1, which unfortunately takes a more severe course of liver disease than other genotypes. We have in Africa, we have genotypes 5 to 8. And this is relevant, for example, it has been described in cohorts from France and also from London, where many immigrants from Africa live, and they carry frequently the HDV genotype 5. For example, the group at the King's College in London, they published a paper where they investigated the natural history of genotype 5 infection and also response to interferon treatment. And the good news for those patients is that the liver disease is more benign than genotype 1 infections, and that patients respond better to interferon. So in distinct settings, HDV genotyping may be of importance. For example, if you treat a cohort in Paris or in France or in London with many African immigrants. For me here in Hannover in Germany, we screened a couple of hundred patients and 97% had actually genotype 1 infection. So I do not genotype my patients unless they were born in Africa. Then I genotype those patients to really know whether we have a different genotype. By the way, for those of you listening, for example, from South America, in the Amazonian area, we have genotype 3 infection. So it's not in entire South America, but it's really in Peru, in West Brazil, and Venezuela. There you may have genotype 3 infection, which takes a more severe course of liver disease, while the frequency of Delta, for example, in southern Brazil or in Argentina or Chile, is much lower. And there you also find mainly genotype 1 infection. But genotype 3 is really a problem in South America. So we've discussed screening with antibodies. We've been discussing the importance of HDV RNA testing. And here, please use the most sensitive assays, which have been on the market since 2 or 3 years. And we discussed HDV genotyping. I mentioned already Delta is the most severe form of viral hepatitis. And therefore, you have to, after you have made the diagnosis of infection, you have to do your homework as hepatologists and to stage liver disease. Here, have a close look at your patient, because the classical non-invasive markers, AbbVie score or FIB4 or something, they don't work well in Delta. And therefore, I'm still biopsying many of my Delta patients, not only to stage liver disease, but also to look for a distinct feature of Delta, and that is that Delta may be associated with some kind of autoimmune liver disease. Delta may trigger some kind of autoimmune hepatitis, and that in the end, obviously, you can measure quantitative IgG levels in the blood, but in the end, I need a liver biopsy. And therefore, I'm still biopsying most of my Delta patients, and frequently I get some surprising findings. This may change over the next years, but at this stage, I think it's very useful. In addition to doing my usual workup in terms of liver biochemistry, hematology, I do my liver stiffness evaluation. But even here with liver stiffness measurements, FibroScan, we don't really know the cutoff when we should call this cirrhosis. So is the cutoff FibroScan 12, 14, 16, 18? This has not been established for Delta. I think this is also very important. So we have done our virology homepage. We have done then our, let's say, hepatology homework and staged liver disease. And then obviously the question is asked, the patient is asking for treatment. So for more than 30 years, we've been using interferon. We've been using type 1 interferon, recombinant interferon, and for the last 15 years, pegylated interferon. Here in Germany and Turkey and Greece and Romania, we've been performing large trials where we treated patients either for 48 weeks or even for 96 weeks with pegylated interferon alpha. The short message of all of these trials, which we published in 2011 in the New England Journal of Medicine and 2019 in Lancet Infectious Diseases, is that roughly 25 to 30% of patients respond to treatment. And they also, some of them, let's say 20% maintain an off-treatment response, but prolonging treatment from 48 to 96 weeks does not prevent relapse in the long term. So it does not make sense to extend treatment with interferon. Secondly, interferon obviously has side effects. Not every patient can be treated with interferon. And the third message is, when we treat delta, we want to reduce HDV RNA, but you may then ask, well, the patients are still infected with hepatitis B. So what's about S antigen decline? And we've been using interferon also to treat hepatitis B. And here, our experience is that the patients losing S antigen in delta treatment with interferon, this proportion is very low. It's only 5%, 3 to 5%. So I'm measuring quantitative HBs antigen levels during interferon treatment of delta. And there are few patients who indeed show a decline in quantitative S. And these are the only patients where I extend treatment beyond week 48. So extending treatment to more than 1 year has not the aim to increase HDV RNA responses, but rather to cure the underlying hepatitis B virus infection. In few patients, it's possible. And to decide whether this is a goal, you need to quantitate HBs antigen. This is the only tool really that can guide your treatment decisions. So now I mentioned interferon, 1/3 to 1/4 to 1/3 response, many side effects, not every patient can be treated. And what I did not mention, even late relapses we reported. So I had one patient who relapsed 7 years after being called as SVR patient, and then he relapsed with the same virus. So I never use the term SVR in delta. I only call, let's say, off-treatment response, maintained off-treatment response, but follow your patients in the long term. So interferon an option, but not really exciting. Exciting is that we have, since September 2020 in Germany, I can prescribe bulevirtide. And bulevirtide is an entry inhibitor targeting the HBV entry receptor NTCP, which is a bile salt transporter. Bulevirtide is a peptide, which you have to derive from the large HBs antigen. So it's basically mimicking HBV particle. It's occupying the receptor, and then HBV cannot enter the hepatocyte. Bulevirtide is a peptide, and therefore it has to be injected on a daily basis. The European Medical Agency granted conditional approval to bulevirtide based on small phase 2 studies. The phase 2 studies confirm that viral load is declining and that liver enzymes are improving. And as there was no approved alternative available for patients not responding to interferon, EMA said, okay, we have something, there's nothing else, we have to give conditional approval. The pivotal registration trials are ongoing right now for bulevirtide, but in real world, we have been treating many patients in Germany, and what have we been seeing beyond the phase 2 trials in our real world experience? The first message is the findings we saw in phase 2 trials have been confirmed in real world. So HDV RNA is really declining when you inject bulevirtide on a daily basis. Secondly, ALT levels are indeed improving in the majority of patients. And third, we also see increases in bile salts in the blood, which you would expect by the mode of action. Because if you block a bile salt transporter, the mode of action should lead to an increase in bile salts. And that is indeed what we measure in the blood. But importantly, this increase in bile salts has not been associated with any symptom, with any side effect. Also, just on a note, this increase in bile salts did not lead to itching. So bile salts per se do not cause itching. This is something important for understanding bile salt physiology, but that's not the topic of today. However, in our real world, let's say not everything was fantastic. We also saw patients who did not show a major HDV RNA decline. And we don't know really why. It's a small proportion of patients, but not every patient is responding. We also saw some patients where even after an initial response, we saw an increase in HDV RNA, which was not due to development of resistance or something like this. And the mechanisms behind this increase are not fully understood at this stage. The other point also I want to mention, some of you may ask, so if I mentioned before that we have been using interferon to treat HDV infection. We have now the new tool, entry inhibition by bulevirtide. Why not to combine both ideas? This also has been studied or is currently being studied in smaller phase 2 trials. There's also some real-world experience from France, which has been presented at the last liver meeting, where they showed a synergistic HDV RNA decline in these trials. However, we lack really strong off-treatment data. So if you do not lose HBs antigen and you have a more pronounced HDV RNA suppression by combination treatment, many patients still relapse after the end of treatment. And therefore, I'm not using this combination treatment in my real world practice on a broad scale. There may be single patients, but this is, unless more data from clinical trials are available, I would not recommend this. But the final points are really now, which I've been frequently asked, is around bulevirtide treatment. The question is really how long to treat with bulevirtide. And I can, at this stage, I don't know the answer. The ongoing phase 3 trial is investigating 2 versus 3 years of treatment. And then all patients will stop treatment with bulevirtide. And then we will see how many patients actually will relapse in the end and whether some patients can be treated in the long term with finite bulevirtide treatment. Currently, if I initiate treatment, in particular a patient with liver cirrhosis, I continue treatment for life probably because I don't want to take a risk in cirrhotic patients for severe relapses. So this is the first question, how long to treat. The second question is the currently approved dose of 2 milligrams daily the optimal dose, and or is a higher dose of 10 milligram better? This is also currently being investigated in the phase 3 trial. Preliminary data suggests that we may not, let's say, see a dramatic dose effect, and it may well be that we treat the majority of patients still also in future with 2 milligram, and only in some patients we may increase to 10 milligram. And the last question I discussed briefly already is combination with interferon strategy. And here, yes, for some patients it could be an option. Interestingly, we saw that also we saw a decline in HBs antigen in combination treatment with 2 milligram, which was not the case in monotherapy with bulevirtide. So the strategy to combine interferon with bulevirtide may also be in the long term to cure not only Delta but HBV infection. And therefore, I'm curious to see also data of bulevirtide plus interferon in HBV monoinfection. I think that would be really exciting and would open a completely new field of discussion. In the pivotal phase 2 trial, there were 15 patients treated with 2 milligram bulevirtide and interferon, and 7 of those cured B, which is a spectacular cure rate, but obviously small numbers at this stage. So to sum up, I think I hopefully convinced you that Delta is an exciting area of clinical research, of basic research. I didn't have the time to discuss with you all the fantastic data which we have seen, but it's definitely an important disease. We can diagnose this. We have to do our homework to really identify all patients with HDV infections because we have new treatments. And here I discussed with you the new treatment options. Bulevirtide is certainly a major step forward, but it's, let's say, not answering all questions in the long term. And so we have to continue to follow our patients. We have to continue to perform research in this field. In the end, hopefully we can help many patients and to improve the outcome of these patients with a very severe liver disease. Thank you very much. And hopefully you enjoyed this podcast.
Thank you, Professor Wedemeyer, for sharing your insights with us. And thank you for listening. Look out for more episodes in this series at clinicaloptions.com/hepatitis.